Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question in this series of questions from one of my clients, Robert. And the question last week was part 4 of my 68-year-old mother is in intensive care with gastric perforation and she's not waking up after the surgery. Will she need a tracheostomy? You can check out last week's episode by clicking on the link below this video. In this week's episode of Your Questions Answered, I want to answer the next question from our client, Robert, which are excerpts from email counseling and consulting sessions with me. And the question this week is, my 68-year-old mother is in intensive care with gastric perforation and she's not waking up after the surgery. Will she need a tracheostomy? And today is part 5 of this series of questions from Robert. So Robert describes his mother's situation as follows. Robert writes, Hi Patrick, thanks for your last email. After having discussed this internally with the family, we're inclined to proceed with a tracheostomy rather sooner than later, i.e. we want to shoot for Wednesday, the day after tomorrow. Our rationale is we are emotionally past the point of trying to avoid the tracheostomy. It turns out in a month or two that she's completely off the ventilator and doesn't need it. It's a somewhat reversible procedure from our understanding. And as you've mentioned earlier, it's actually more comfortable to have the tracheostomy compared to being intubated and having the breathing tube in her mouth. We are also a bit worried that this is already her third intubation in the last few weeks. There's a chance that after extubation she struggles again with her breathing. We are also worried that the longer we wait, some other complications will come up, like another infection, thereby closing the window for a potential tracheostomy. So, assuming the staff is okay with it, we'd like to make a strong request for Wednesday and not wait until Thursday or Friday. So, 2 questions on that front. Number 1, how long does Keppra usually take to wear off? And for our listeners and people who watch this video, Keppra is a medication that's given to prevent or avoid seizures. And the next question that Robert had is, how important do you think it is for an attending surgeon to do the tracheostomy versus a resident? And a resident is a more junior doctor. My leaning is to solve for timing, schedule instead of who does it, given the timelines and the urgency of the situation. One other related set of questions that I have is, the hospital staff have asked what our position and decision is in regards to hemodialysis for kidney failure if it's needed, and also chest compressions if it's needed in case my mother's heart stops. Our position is that dialysis is okay and should be pursued, but we likely don't want to do chest compressions from what we've heard. It's a last, often desperate measure and very aggressive or even violent. Now, having said all of that, my leaning right now in the situation we're in is to communicate that our position is whatever means are necessary to keep my mother alive. This is primarily to show conviction and keep things simple as we work through what might be a potentially tricky situation this week. After the tracheostomy, we can always change our mind and communicate that we don't want chest compressions. What do you think? Thanks as always from Robert. So, here is my response. Hi Robert, I believe it is wise to proceed with the tracheostomy rather sooner than later, as your mother will get the best of both worlds, so to speak. You are absolutely correct to point out that your mother already had 3 intubations in the last few weeks, and hence another extubation, and then having the risk for another intubation is probably too high. Also, please keep in mind that for another intubation, there would be sedatives and opiates needed as well, similar to when a tracheostomy is being performed. The good news in all of this so far is that your mother's heart continues to be strong, hence why she's off the inotropes or vasopressors, and she can therefore maintain a sufficient blood pressure for now. A strong heart is important during critical illness for a number of reasons, including avoiding dialysis, and I will come to that in a moment. In some instances, although not all, after a tracheostomy has been performed, patients can be taken off the ventilator within 24 to 48 hours, at least for a couple of hours to begin with, and if they can tolerate the first weaning trial, the time off the ventilator can be gradually increased. In some instances, patients can go from having a tracheostomy to coming off the ventilator straight away. One of the biggest risks for complications that I can see is your mother's prolonged time on the ventilator with a breathing tube already, and hence there is an increased risk for a chest infection or pneumonia. Therefore, again, I strongly believe the tracheostomy is the quickest way to minimize that risk from my experience. Your mother's conscious state and still not waking up is of course still a concern, but I keep referring back to the CT scan and the MRI scan of the brain, which I believe shows no brain damage. Therefore, if no other neurological complications occur, there is a very high likelihood your mother will wake up in her own time. You mentioned that she had a stroke in the past, hence the Keppra, and I assume it would have been a mild stroke from what you've mentioned. Otherwise, she wouldn't have been able to travel to Brazil. The half-life for Keppra is 7 hours plus minus 1 hour, and it's being excreted by the kidneys. From my experience and from all the information you have shared with me thus far, your mother not waking up yet is a combination of being on strong sedation on and off for quite some time, and she would have also had either morphine or fentanyl intravenously for pain relief while she was or still is intubated, and that delays waking up as well. I would be curious to know if she's still getting either morphine or fentanyl intravenously for pain relief, not only to tolerate the breathing tube, but also to deal with the abdominal pain after the surgery she had. Now, to your next question, looking at who should be doing the tracheostomy. I actually think it's great that either the surgeon or the resident is doing the tracheostomy. The reasons I'm saying this is that in the old days in intensive care, tracheostomies were performed in the operating theatre. And nowadays, in most ICUs worldwide, a qualified and experienced ICU consultant is able to do them. That's okay. However, doing a tracheostomy is still a surgical procedure, and hence if a surgeon or their registrar is doing it, I think that's fine, especially since a fully qualified surgeon is overseeing the procedure. I would have faith that this would be going smoothly. I remember in the documents you sent me, the surgeon was saying that the anatomy of your mother might be an issue. That's why they might have gotten the surgeon on the case in the first place. Normally, if the anatomy of the neck in particular is normal, an ICU consultant can do the procedure. Now to your other questions, Robert. I would definitely say yes to dialysis, and I would at this stage still say yes to cardiac compressions. Your mother's heart is beating strong, making it less likely for her needing dialysis. Dialysis is generally speaking needed for kidney failure, as you would know by now. And kidneys can fail in ongoing severe sepsis and during prolonged low blood pressure. The sepsis your mother is fighting seems to be okay for now, and therefore hopefully she won't need dialysis for the kidney failure. With the heart being so strong thus far, unless there is a heart condition that you haven't shared with me, I would strongly advocate cardiac compressions, also known as CPR, especially in light of the fact that the intensive care team has mentioned withdrawal of treatment at some stage already. By you stating that you want full treatment, including cardiac compressions, you are keeping all your options open thus far. And you are showing the team that withdrawing treatment at this point in time is not an option for you and your family. And as you have correctly pointed out, you can always change your position down the line. I hope that helps, Robert. I'm looking forward to your next email with another update. So, how can you become the best advocate for your critically ill loved one, make informed decisions, get peace of mind, control, power, and influence quickly whilst your loved one is critically ill in intensive care? You get to that all-important feeling of making informed decisions, get peace of mind, control, power, and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision-making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care and how your critically ill loved one's treatment may depend on those competing interests, how to eliminate fear, frustration, stress, struggle, and vulnerability, even if your loved one is dying. You get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You'll get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You'll get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also check out our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Or you can call me, find international phone numbers on the Contacts tab. Also, check out our ebook section where you get more ebooks, videos, and audio recordings, and where you can also get one-on-one counseling and consulting with me via Skype, over the phone, or via email by clicking on the Products tab. This is Patrick Hutzel from intensivecarehotline.com, and I'll see you again next week in another update.